Hey there. Welcome to the third monthly webinar for Neurocritical Care on Call. This month's topic is prognostic assessment in neurocritical care. And my name is Dave Huang. I'm one of the neuro ICU attendings at the Yale School of Medicine. And I co-authored this particular topic in Neurocritical Care on Call with Karen Hirsch and Liz Fox at Stanford. Prognostic assessment is a huge part of neurocritical care practice. Often how practitioners and families feel about a patient's prognosis drives how aggressive care is. And these assessments can often happen even very early on in patient's stay. This short presentation will focus on three different topics. First, we will talk a little bit about the general challenges with formulating prognosis for neurocritical care patients. We'll spend a little time surveying the different clinical scales that are available for specific diseases in the neuro ICU. And we'll end with a brief discussion on the challenges with actually communicating prognosis, even once you've formulated it with patients, and in particular with patients' families. I think all who are listening to this webinar probably recognize the fundamental uncertainty that's inherent with the act of formulating prognosis. But there's a recent study in neurology in 2016 that really just highlighted the extent to which this uncertainty can be a problem. For example, consider that a 76-year-old woman with no past medical history who is intubated and presents to the ED with an intact brainstem exam, a Glasgow-Coma scale of 70, and 120 cc intracerebral hemorrhage with the screenshot of the CT that you can see here. It asks you just to consider a couple questions. Number one, just looking at this vignette and this CT, it asks you to consider what is your best estimate of 30-day mortality from a scale from 0 to 100%. And I'll also ask you to consider in your mind what is your recommendation on intensity of treatment at the time of admission if someone were to ask you to rate your recommendation on a scale from 1 to 6, with 1 being a less aggressive care, being comfort measures, and 6 being full intensive treatment. As you consider your answers to these questions, I'll just state that these questions were actually posed to more than 700 neurology and neurosurgery experts across the country in a national survey, where vignettes such as this one were given to folks, and folks were asked to record their estimates, and those estimates were collated by Darren Zahurinek's group at the University of Michigan. So for the vignette that you saw on the last slide, here's what Darren's group found with regards to the answers to the first question about 30-day mortality. Here you can see the range of responses that physicians gave with respect to this question in this particular patient. And you can really just see that the responses are just all over the map with regards to how well they thought this patient would do. You can see here the responses to the second question on the survey, that question about aggressiveness of care. And you can see about 18% of folks who took the survey for this particular vignette recommended full aggressivement treatment. But close to 50% of folks who took the survey recommended something on the lower half of the aggressiveness scale for this particular question. And so you can see that the challenge is not only with prognosticating outcome, but also just the differences in attitudes of aggressive treatment among even expert physicians. You might look at the results of that last study and think to yourself, well, so much for subjective prediction of outcome. What we really need are some scientific methods for trying to assess prognosis for our sickest patients in the neuro ICU. And this is where clinical grading scales that exist in literature seem very attractive for this reason. Many of the clinical grading scales that exist, they utilize admission, clinical, and radiologic variables so that you can use information that's available early on in patient stays. They can be relatively easy to learn and apply and rapidly stratify patients early on. And then there's this sense, as I mentioned, that by using these clinical grading scales and the outcomes that are associated with them, that one might be able to quote unquote objectify early impressions of prognosis. I think a major point of the chapter on prognosis and neurocritical care on call is to really focus um, on the cons of clinical grading scales, even though they do have a purpose and they do, there's a reason why many of them exist. In terms of using them in clinical practice, one has to have some reservations. Many of them have, especially in neurocritical care, have limited validation in different settings and different practice environments. There are self-fulfilling prophecies that are incorporated into the derivation data sets for these clinical grading scales, which we'll go into in a minute when we're talking about the individual scales. It can be very difficult to apply population data or general outcome data to individual patients, their particular situations. And this point can't be emphasized enough in clinical practice. And finally, the outcome scales themselves, the outcome of the scales may not necessarily be meaningful for families. In other words, what types of functional outcomes are predicted by these different scales may not be exactly what families have in mind when they're trying to make life and death decisions. With regards to the last point on the previous slide, one only needs to look at some of the common outcome scales that are used in neurocritical care to get a sense of how they may or may not be meaningful for families. Up on this slide, you see the modified Rankin scale and the Glasgow outcome scale, two of the most common outcome scales used in neurocritical care studies. And oftentimes, what is considered a good outcome in many studies is displayed here by the line that's drawn across the screen, with those outcomes above that line being quote-unquote good outcomes, and those outcomes below the line being quote-unquote unfavorable or poor outcomes. But looking at the modified Rankin scale, you can see that for those that are below that line, immediately below the line, the modified Rankin scale of 3 and 4, that it's possible that folks may have that particular modified Rankin scale, but still have what they personally consider to be a reasonable quality of life. And trying to navigate these sorts of discussions and value judgments with families is critically important when discussing prognosis. I'm going to pivot now from talking about some of the challenges with formulating prognosis to surveying some clinical grading scales that exist for the different common diseases that we see in the neuro ICU. I know I had spent some time talking about the pitfalls of using the scales, and they definitely apply. But that being said, it's important to be aware of the major scales that form the language for communicating about diseases in the neuro ICU. We're going to talk about stroke, intracerebral hemorrhage, subarachnoid hemorrhage, and traumatic brain injury. And I'm going to leave off cardiac arrest, even though prognostication is a huge part of cardiac arrest, simply because it was a topic for last month's webinar. With regards to ischemic stroke, one of the most common situations we find ourselves as neurointensivists prognosticating is outcomes after large hemispheric MCA stroke. And what you see here is the outcome data from a pooled analysis of 3 major craniectomy trials in patients less than age 60 years and younger. This data is from the last decade, and you can see the outcomes split between those patients that received conservative treatment or those that did not go for craniectomy and those that went for surgery, craniectomy in these trials. The green bars represent those with modified Rankin scale of 2, and those are the patients who are able to live without any assistance following their ICU stay. So these numbers that you see here can give at least a ballpark of what we might be able to expect for those who are relatively younger, who go for either go for craniectomy or don't go for craniectomy, but who survive after large MCA stroke. The similar data for hemispheric stroke patients who are age 60 or above is a little bit more challenging in the sense that the outcomes are they're just simply poor. You can see here again a similar a graph of those who received craniectomy versus the control group for the Destiny 2 trial that was published a few years ago. And you'll see that while in the craniectomy group, there's certainly a small proportion of patients who died in long-term follow-up. There were no patients in either group of this particular trial that had a modified ranking scale of 0 to 2 or who achieved functional independence. So these are sorts of things that this sort of data is something that one needs to consider when discussing craniectomy for older patients with their families and with regards to what quality of life patients might find acceptable. Now, while the craniectomy data I just showed you is often cited in clinical practice because it is the best randomized control data that we have for assessing or predicting outcomes, there are a large number of clinical grading scales that have been developed for ischemic stroke, many of which you can see on this particular page. The majority of these particular scores, with the exception of the NIH stroke scale, that are rarely used in clinical practice simply because they all represent heterogeneous data sets with varying involvement of TPA patients and thrombectomy patients. Just as an example of what these clinical grading scales might look like, I'm showing you a screenshot of the I-score. The authors of this particular score have created an online calculator where one can go type in their different patient characteristics, and one can see in graphical display a number of the different outcomes, including mortality and functional outcomes that are available. And moving on from ischemic stroke to intracerebral hemorrhage, there are many different grading scales that have been created for intracerebral hemorrhage. Listed here on this slide are the majority of them, and I'll say that most of these have been were developed with single center data sets that represent really clinical practice patterns in different areas around the world. Of all the available clinical grading scales, the original ICH score is the scale that's still most widely used in clinical practice and in communication among practitioners. You can see this classic scale and its components listed here on this particular slide with the scores available from 0 to 6. This figure here that you're looking at is taken from the original manuscript for the original ICH score, where different values for the ICH score correlate with 30-day mortality in the original cohort that was used to develop the scale. But a more recent study has highlighted just how the self-fulfilling prophecy can be baked into these scales based on local practice patterns. This diagram that you're looking at came from a recent study where 5 different medical centers made a practice agreement where any ICH patient that came in would receive as a default 5 full days of aggressive medical treatment with no limitations even on code status. They collected outcomes data on about 100 ICH patients after this practice change. And they looked at the correlation of the ICH score with 30-day mortality. And what you see here in green are the predicted outcomes based on different ICH score values for these 100 patients. And in gray, you can see what they actually observed in clinical practice with regard to their 30-day mortality. And this decrease that you see from the green to the gray is a visual representation of how the self-fulfilling prophecy can be baked into the scales depending on local practice patterns in the cohort that's used to develop any particular grading scale to begin with. Of note, the original ICH score was validated for 12-month functional outcomes in 2009. And you can see here some useful graphs that show how different values on the ICH score might correlate with different degrees of functional recovery. This data can be useful with regards to discussions with families, as different families may have different thresholds for different outcomes that they may think are important to the patient with regards to recovery. The figure on this slide is meant to make a point about how it can be difficult to apply clinical grading scales or population outcome data to individual patients in clinical practice. We at Yale worked with several other medical centers and conducted an experiment where, for ICH patients that came in, we had the clinical attending taking care of the patient and the bedside nurse taking care of the patient, make an assessment of what they thought the patient's modified Rankin scale would be at 3 months. But we asked these predictions to be made on a piece of paper within 24 hours of patient admission to get a sense of what folks' early impressions or prognosis might be. And I showed you the slide earlier about how these subjective predictions can be all over the map. But we did an experiment where we correlated these predictions with the actual outcome at 3 months. And then we looked at the correlation of the ICH score and another clinical grading scale, the FUNC score, with 3-month outcomes as well. And it turns out, even with the pitfalls of subjective prognostication, we found that the accuracy of attendings and nurses outperformed those of the ICH and the FUNC score to a fair degree, and that this was the case even once you took out those cases that were immediately headed for early goals of care. So the take home here is that even though subjective predictions on the part of expert clinicians can be challenging and can be all over the map in certain different cases, that at the end of the day, the attendings and nurses taking care of patients have a wide array of information available to them that are not necessarily incorporated in clinical grading scales that must be accounted for ultimately when formulating prognosis. With regards to ICH clinical grading scales, I'll take the time just to highlight one of the newest scales that has been published. This was published last year, the max ICH score, which rates patients or grades patients from a scale from 0 to 10 based on the components that you see on this particular slide. The reason why this particular scale is called the max ICH score is that it was developed in a cohort of patients who were treated maximally without any limitations of care. And you can see here the functional outcomes at 12 months that correlate with the different levels of the max ICH score. This particular score has not yet been validated outside of its initial cohort and practice in Germany. Moving on to subarachnoid hemorrhage, we won't spend a lot of time talking about the different scales available, except to say that the mortality numbers that have been associated, or mortality estimates have been associated with the different levels of different scales, have really evolved over time. The Hunt-Hess scale is one of the most commonly known scales for subarachnoid hemorrhage that was developed back in the 60s. And what you can see here are the mortality numbers that were associated when Hunt and Hess initially developed their scale, and then you can compare and contrast that with the mortality numbers with more recent outcome data, and you can just see that the difference that's there. These estimates are important when assessing patients and discussing things with families. So anytime that an outcome scale is used, whether subarachnoid hemorrhage or not, understanding the age of the data and whether or not it represents current clinical practice estimates is vitally important. As an alternative to Hunt-Hess, the World Federation of Neurological Society scale can be useful too, as the different values for the scale have been correlated with functional outcome as opposed to just mortality, which you can see here on this particular slide listed. In contrast to the Hunt-Hess and the WF&S scales, which are clinical grading scales, the modified Fisher scale is a radiologic scale for subarachnoid hemorrhage that's mostly been developed to help predict the risk of cerebral vasospasm that patients might run into. This scale is often used to help judge how long patients need to be observed in the neuro ICU through that vasospasm period. And you can see the different odds ratio for clinically significant vasospasm that correlates with the different levels of the Fisher scale with their radiographic correlates here. I've listed here a wide array of different subarachnoid hemorrhage grading scales that have otherwise been developed in the literature. Some of these, like the I-score I showed you for ischemic stroke, have online calculators or even iPhone apps that one can use to look at outcomes. They come with the same caveats with regards to clinical grading scales that we discussed earlier for for stroke and for intracerebral hemorrhage. Now, for severe traumatic brain injury, the choices of clinical grading scales, if you already utilize one in clinical practice, are a little bit easier simply because there are fewer that exist, and those that do exist have come from large multi-center cohorts with thousands of patients. For moderate to severe blunt TBI, you're really looking at the impact and the crash calculators and prognostic models that exist. And with regards to penetrating TBI, Suzanne Muschlegel and her colleagues recently published the SPIN score that was in neurology quite recently. Here's a screenshot from the online calculator for the crash score. And what you'll notice that's interesting is that because it was such a large data set that they used to create the crash calculator, the prognostic model asks not only for clinical information about the patient, but even which particular country the patient is coming from. This mitigates to some extent this idea of how different practice patterns locally might not apply from country to country or situation to situation. Here you can see if you keep the patient the same, but you change the country from Afghanistan to Germany, there's a difference in the online calculator's estimates of what 14-day mortality and what unfavorable outcome at 6 months might be. We've reached the end of close to the end of the webinar, and I just wanted to close this particular presentation just by talking a little bit about some of the challenges with communicating prognosis to families after you've formulated what you think your opinion might be. The chapter in the Neurocritical Care on Call website on prognostication has a very detailed section on running family meetings and how to communicate. And we just wanted to highlight a few principles here at the end of this presentation. The first point we wanted to point out is that in communicating with families about prognosis, your particular opinion or the medical team's opinion about what prognosis might be is only a very small percentage of what the patient's families report using to create their own assessments of prognosis. This is data that you're looking here from a bunch of interviews with surrogate decision makers in general ICU, where folks were asked about what contributes to their impressions of prognosis for their loved ones. You see only 2% of folks who participate in this study reported that the physician's prognostic estimate alone is what they relied on for their own impression of prognosis. About closer to 50% said it was a partial role of what the physician or the medical team said, but on the slide you can see an array of other factors such as the family's impressions of the patient's intrinsic qualities, their impressions of the physical appearance of the patient, the patient's survival, prior illnesses, that all these play a huge factor in how surrogates assess prognosis in their own minds. I think many of us who have had experienced talking about prognosis and goals of care with neuro ICU patients' families recognize that there's a tendency for families to have optimistic bias when formulating prognosis on their own. But the degree to which families might do this, I think, is really well highlighted with this particular study. This was a study where a number of surrogate decision makers in ICU were given a series of hypothetical prognostic statements and asked to rate on a scale from 0 to 100% what they thought the chance for survival for their loved one might be if they were to hear these particular statements from a doctor. And some of these statements are rather vague. For example, up top, the statement, "I am concerned he will not survive," like hearing that from a doctor. Folks were asked to mark on this scale from 0 to 100% what they thought the chance for survival might be. And you can see here that these responses here were all over the map here. This is a box and whisker plot. You can see the X here is the mean response, and the diamond here is the median response. You can see that the range of the whole responses for this particular hypothetical statement were really all over the map. You can contrast that here with these more definitive statements down below. For example, he has a 5% chance of surviving, or even he will definitely not survive. And you can see here that the median response for this 5% statement was closer to 15, and this median response for he will definitely not survive, which was 10%. And what's perhaps even more noticeable is just, again, the range of different responses that one could see with regards to these particular statements is really quite striking and really highlights the optimistic biases that families might have in these particular situations when speaking with physicians. Even how quantitative numbers are given to families can have a profound effect on their impressions of risk and the patient's prognosis during family discussions. This particular study was done in Australia, where a number of surrogate decision makers were given the statement, the hypothetical statement, "Your relative has a blank chance of dying in the next few days." And they were asked, after hearing that statement, where the blank was a number that was given to them. They were given this scale that you see here, and they were asked to rate the risk to your relative of dying with a cross on the scale. So, for example, if a family heard that statement and felt that their loved one was not really at risk for dying, they would mark an X here on the lower end of the scale. And if they felt that it was certain that their loved one was going to die, they marked a higher number on the scale. And what was interesting is they varied up between different participants of how the number in the blank was framed. For some, they gave a probability. They gave a probability in percentage, such as like 2%. And then for others, they expressed the probability as a frequency, such as 1 in 50. Now 2% and 1 in 50, for those of you that like math, are the same. They're basically numerically equivalent. But you can see the median number that was marked on the scale was different between the two groups. Statistically significant. And this phenomenon of how percentages seem to be lower risk than frequencies, or at least perceived as lower risk than frequencies among the majority of surrogates, has been reproduced not just in critical care, but in different studies in oncology as well. This is the last study we're going to highlight in the talk, and it really just focuses on this issue of how affective forecasting, or the attempt to predict how someone might feel about something in the future, is a very difficult thing to do. There's a well-known, well-written about phenomenon called the disability paradox, which highlights the different biases that one might run into when trying to advise families about how a patient might feel about a disability that they might have in the future. If you look at the top of this particular slide, you'll see how a model of quality of life that a patient might perceive after a transient ischemic event of some sort. So in this situation, a patient might have a stroke deficits that resolve completely, and their quality of life is represented by their expectations and their actual experience or their deficits and the gap between the two. The stroke, when it happens, causes a dip in the experience, but then once those deficits resolve, the experience the experience goes back to baseline and matches back up with what that patient's expectations might be. Now, when we're talking about goals of care with families, there's a tendency to think of a disability and quality of life as what you see here under part B of this diagram, where the stroke deficits stay, but the expectations about what life should be do not change. And so that after the stroke, there's a huge gap between experience and expectations that may cause us to believe that a patient may have a lot of suffering and a poor quality of life. Now, what's described in the in interviews with stroke survivors and in the literature is that stroke survivors actually have a large capacity for response shift much of the time, more than one might expect, so that the initial quality of life gap might be large following the insult and following the injury, but that with time, folks' expectations might change, and that the gap between their expectations and their deficits are no longer great, and they actually report a better quality of life than one might have expected, especially out front when oftentimes the prognostic discussions and goals of care are being made. So just awareness of this particular paradox is important as we advise families about prognosis and about how aggressive care should be in terms of trying to preserve quality of life for their loved one moving forward. And with that, that brings us to the end of this presentation. As I mentioned before, the chapter on neurocritical care on call and prognostic assessment contains a wealth of more information about different clinical grading scales available for different disease types and a much expanded section on family meetings and how to conduct prognostic discussions. So we encourage you to check out that chapter. To summarize this particular presentation, we would encourage you to be careful with your early impressions of prognosis, especially understanding how uncertain these can be and how variable impressions of prognosis can be, even among expert providers. Clinical scales and algorithms can provide a framework for risk assessment, but do not replace, at the end of the day, expert clinical judgment. And awareness of common biases that can affect how one communicates prognosis to patients' families is vitally important for making sure that we respect families' wishes and at the end of the day really respect their try to achieve substitute judgment as best we can for those patients that can communicate on their own. With that, we'd just like to say thank you, and we wish you the best of luck in your discussions with families about those sickest patients in your neuro ICU.